come on. Hi, everybody, and welcome to this next webinar from Vigon. Just to some practical things, just to make sure that you can hear and see us. It's important that you can see and hear, of course, the guys and not me. But if somebody could very kind, in the right-hand side of your screen, you've got a chat box. If somebody could very much to just type in to confirm. There we go. Brilliant. Okay, so everybody can see.
Thank you.
That's brilliant. Thank you so much. That's great. Whilst we wait just a couple more minutes for people to join, we will be using Menti. We thought, why limit the opinions of the world to just Segun and Adrian? So we've actually opened it up to the whole world. So go to Menti, get hold of your phone and go to menti.com. and enter the code that's at the top of your screen, and you'll be able to access questions. So if we just want to go back to the home screen for the moment, Mohammed, if we just go back to the beginning, that'd be, we'll stay there for a minute, and you can enter that code, and then you'll be able to join in as we go through. Thank you. Hi, Lindsay. And is that Iman? Nice to meet you. I'll do some formal introductions shortly, but you can see everybody. I've got Adrian Wong on the right-hand side of your screen, and I've got Dr. Segun Olusanya as well. So he should be just there as well. So there we go. We've been chatting just for the last couple of minutes, and I have to say, these guys are really interesting. They do know how to debate. So we are.
We'll get you everywhere.
Interesting is a very safe descriptive term, isn't it?
Yes. Yes.
I'm just glad that we're friends.
I would have been a lawyer in a different life.
Oh. I'm really looking forward. I'm really looking forward to it. So for the people that are tuning in, thanks for tuning in. But make sure if you've got any questions that you want to hear discussed, shared, talked about, if you put them in the chat as well. We promised David that we would do our best to monitor everything and answer any questions. There are no right or wrong questions, and the more provocative your questions are, we will still do our best to answer them. Isn't that right, Segs?
Absolutely. There's no controversy that's too big or too small. This is coming from somebody who actually I wrote 2 articles challenging the surviving sepsis guidelines. So there is no controversy.
And he still works as a consultant intensivist.
Absolutely.
Okay. It's 2 minutes past 6 o'clock Central European time, and it's time to start this wonderful webinar with Dr. Adrian Wong, a consultant in intensive care at King's in London, and our great friend as well, Dr. Segun Olusanya. He's consultant intensivist also at St. Bart's in London. So it's really a great pleasure to have you both here on World Sepsis Day to discuss what do we know, what don't we know, and where do we go from here. People, it is an interactive event. I'm going to vanish in a minute, and I'll come back for questions at the end. But please go to menti.com, enter this, the code that you see at the screen, and then you can start to join in. And our first question is here for you. So anyway, that's enough of me, and let me hand over to Adrian and Segun. Enjoy.
Hey, Adrian, always a pleasure to be here and chat with you. So why don't we start? What shall we start using this question that we've asked as part of our framework? So we're starting off in the section of things that we know. And one of the things that we definitely do know is that there is an international surviving sepsis guideline that has been published, initially published in 2002, and is now in its 3rd, 4th iteration, with the last guidelines being in 2021.
I counted as 4th.
I think it's the 4th one now. Yeah, so so please vote and let's hear, whether you follow the international sepsis guidelines or not. Adrian, do you follow the surviving sepsis guidelines in King's?
Some of it, not all of it. I think, well, let's be honest, I think the surviving sepsis campaign guidelines divides opinion within the world of critical care. I think my general feel is that it mostly is a force for good. I can say that. But I think one of the criticisms of the surviving sepsis guidelines is that it's not so much the guidelines, it's the implementation. Guidelines are guidelines. They are a suggestion for best practice. And I think one of the reasons why the surviving sepsis campaign guidelines have been getting such a bad press is because of the implementation. There are some people, some bodies, some institutions which essentially says you shall do this or else. Your thoughts, Segs?
Yep. Yeah, so you're talking about with the latter. You're talking about our American colleagues and Rory's Rule, I believe it's what it's called, in New York, where basically the surviving sepsis guidelines and certainly the 1 hour bundle is pretty much mandated in hospitals, and if you don't provide it, then you get a telling off. In BARTS, again, we follow aspects of it, and we have kind of our own local modification because we have slightly different patients, and we're a big cardiothoracic hospital, and so therefore recognition of sepsis is very important for us. However, because we have such a big post-surgical and post-MI population, recognizing sepsis is actually really difficult because pretty much everyone, certainly like our CCU, for instance, they've had a heart attack within 24 hours. They all have SIRS criteria, and they've often got fevers, and they've often got a leukocytosis. And so differentiating sepsis there can be really difficult. So we have to follow kind of the guidelines, but with some modifications. And the main thing here is clinician suspicion and relying very heavily on a pre-test probability. And what are your thoughts on that aspect of it? The guidelines still very much rely on you being able to think, could this be sepsis?
I think the main benefit of the surviving sepsis guidelines, in my humble opinion, is that it raised awareness of sepsis as a whole. Okay,
100%.
So there is a day now, September 13th, where it's the World Sepsis Day. We are slightly, dare I say it, in our ivory towers when we work in critical care, because we work with a very specialist, usually well-staffed area with a lot more resources than a lot of places, departments within the hospital. So it's easy for us to say, well, we should have done this, we should have done this, we should have done that, you should have done this, you should have done that. But actually, Joe Public, colleagues in perhaps less well-resourced areas are now thinking sepsis. They're asking the question, could this be sepsis? And go from there. Also, with regard to all the whole public campaign that's been going around with raising awareness, etc., Joe Public knows, Jane Public knows roughly what sepsis is. They know it's a bad thing. They know if we intervene early, it's the right thing to do, improves their chances of getting better. They know to seek help early, not necessarily for themselves, but seek help early for their loved ones who may not be in a position to seek help for themselves. So overall, I think surviving sepsis campaign guidelines have done quite a lot of good, if I'm perfectly honest with you.
Yeah, no, I think you're right, actually, and that brings us on to, I think it might be a good time to move on to our next bit. The results of the poll were quite interesting. Did you see that actually most people follow their own local guidlines rather than?
I think that's really fair. I think that's fair because actually, we don't work in identical institutions with different case mixes, so on and so forth. So I am not surprised, and in fact, I'm very encouraged that people have taken the guidelines and tweaked it to some extent to where they work in locally in their own hospital. So not terribly surprising.
Yeah, I agree. I think that's particularly important in kind of low middle income or low resource settings where you can't necessarily do all of the same things that the surviving sepsis guidelines were designed to do. Although to be fair, the latest iteration were designed with low middle income settings in mind.
Correct.
So this is our next question is an extension of kind of the first one. We're talking about local sepsis guidelines. And again, so please feel free to vote in the Menti and all that, and let us know what your thoughts are. And also feel free to put some stuff in the chat if you want to. So again,
especially if
actually,
you hate the surviving sepsis campaign guidelines.
Yes, please do. So it's nice to see lots of people have local sepsis guidelines or have work in progress. We've just talked about our guidelines. So, Adrian, you've got kind of locally modified guidelines in Kings. We have our own locally modified guideline in Barts. With the big issue, again, coming back to you have to have the initial thought process. So in terms of your triggers, so in terms of your trigger, what are you guys using as your potential code sepsis trigger?
You know what? I've gone past the whole defining the whole cold sepsis, warm sepsis, hot sepsis, tepid sepsis thing.
Good point.
I sometimes I think that we overcomplicate things, and with parameters, with definitions, etc. And a lot of the times, I think when it comes to sepsis, rightly or wrongly, I always feel that it's better to think about it and overdiagnose initially, rather than, I know I'm going to get a lot of slack from medical colleagues out there. I know I'm going to get a lot of slack out there. But I do genuinely think that it's one of those things that if we treat early, there is a potential for improved outcomes. We can come to the last bit of whether it's all predetermined, it's all genetics, anyway, later on. But I don't really have like a definition or things to look for in terms of cold sepsis versus hot sepsis. What I do think, touching upon that field, is the whole aspect around cardiovascular hemodynamic parameters. We both work on the intensive care unit. You work in a cardiac center of excellence. So hemodynamics is what we do, in inverted commas. So I'll be curious to see what people use in what type of hemodynamic monitors people use as far as basis.
We've already got 3. So so Delta X, it would be the soft shield Doppler. Edwards Life Sciences will be so they make all sorts of different stuff: FlowTrack, Vigileo, Pico, and of course we've got Most Care Up from Vigon, which uses pulse control analysis through an arterial line. And that's a really good start. No love for Echo, really? No one?
That's because you and I are not allowed to type in this.
Very good point. So regarding hemodynamic monitoring, okay, so Adrian, what are you using?
So we use Echo. We do use some form. Pardon?
Is that your first line?
No. Okay, so I'll be honest with you. The what we tend to do is still rely on basic blood pressure, arterial line, and then we tend to use a calibrated system pulse control analysis. Okay. We don't use the Doppler. We are in the process of thinking about the uncalibrated pulse control analysis, such as the Most Care, like the Litco Repeat, so on and so forth. For what I think, as a whole, we are moving, certainly my institution, we are moving towards more perfusion rather than blood pressure per se.
Oh, tell me more.
Okay, so the problem, this will sound really cynical, haha, Adrian, cynical. The issue has always been this. We assume in medicine, in critical care, we assume that if you have a good blood pressure, you will have better perfusion of the various vital organs. That is simplistically what we assume. And yet we also know that it's a leap of faith, isn't it? Let's be honest, it's a leap of faith. What we really want is improve perfusion. So when we give a fluid bolus, we're not saying the patient's dehydrated. We want to improve, we want a patient who is preload responsive to improve their stroke volume and ultimately improve perfusion into whatever organ you want. The problem is that we can't really measure perfusion easily by the bedside. We have, however, got an arterial line, a BP cuff. it becomes so easy. It's much easier to do the blood pressure. When it suits us, we go, well, the blood pressure is okay because we can't do this, this, and this. And when it suits us, well, the blood pressure is not good enough because we need to know about perfusion, and go vice versa. So that's why I think we should be moving towards flow, perfusion, rather than blood pressure. Your thoughts?
That's a really, really good point. You've been influenced by Glenn Hernandez. So this concept is hemodynamic coherence. The idea of coupling the macrocirculation, which is your big vessels and your blood pressure and your stroke volume, with your microcirculation, which is the actual capillary beds that are perfusing your individual organs. And we know increasingly more and more from studies in shock, and certainly there was a lovely paper published on it recently, actually, that looked at macro and microcirculation and showed that even if you optimize your macrocirculation, you still have poor perfusion at the microcirculation level. And I have to say I completely agree with you. My saying is pressure is not flow, is not delivery, is not utilization. So you need to make sure that you've actually got adequate delivery right down to the capillary beds and at least some kind of adequate utilization. So I am still using, in terms of micro perfusion, Glenn Hernandez recommendation, which is capillary refill time and skin warmth.
Have you got a microsome slide though? Have you got a microsome slide?
Good point. I'm not doing it properly with an actual with an actual slide and doing it in the proper way that they did in Andromeda Shock. But I'm still using my simple bedside assessment. But I find that that's just such a useful tool at the bedside to try and work out whether you've actually got adequate hemodynamic coherence. There's other things that I'm looking for as well, and I might be looking to, which is using clever contrast enhanced ultrasound, like you guys are using at King. And I'd love to hear a bit about that
at the moment. Yep. Okay. Well, I feel I need to answer the question around Doppler. So the reason why we don't use Doppler, please vote on the Mentimeter thing. The reason why we don't use Doppler is we have got access to Doppler, definitely in an anesthetic area, although we're using less and less, and we don't tend to use it on intensive care setting. The problem with the Doppler is that it's very positional. If I don't know whether that's your experience or not, Sagan, with it. I think the critics will then say, well, you don't really need a fixed number of the Doppler. You just need to look at the response to it. It's very fiddly. So if I'm going to constantly be looking at fixed responses, then I might as well get an uncalibrated pulse contour analysis, which is usually from an arterial line. So it's a trade-off, isn't it? I think a lot of the work on the esophageal Doppler, I remember from, I think it was Howard Wakeling, based in Worthing, UK, who did a lot of that work with colorectal patients undergoing colorectal surgery. So that's where I think the evidence for the Doppler is. Less so on the intensive care unit. And I don't think my intensive care unit is particularly different in not using the Doppler.
No, I have to agree with you. I mean, there is one population of patients in which, certainly in my unit, we are wedded to the esophageal Doppler, and that is people on VV ECMO. And that's simply because otherwise, because pulse contour analysis and using transpulmonary thermodilution doesn't work in those patients because you've altered their flow. Ditto PA catheters. So for those patients, we rely on this esophageal Doppler as our cardiac output monitor at the bedside, but we liberally use echo as kind of our calibration tool to come in and make sure that the numbers we're getting are correct.
Okay, so playing devil's advocate now. Okay, devil's advocate. You've got a Doppler that says the flow time corrected is whatever. Okay, given what you said about the perfusion at a micro circulatory level and the coupling uncoupling that may or may not happen, how do you use it? If you're already using your non-microscope slide capillary refill time, looking at the patient, lactate for sake of argument, what's the Doppler going to do?
So it's a really good point. So for the VV ECMO patients in particular, what we need is a measure of flow and a measure of cardiac performance is very helpful because most of these guys have got respiratory failure, and for the most part, their hearts work okay. But every now and again, you get flow issues because you've got a low preload. And so being able to identify early you've got a low preload is what the Doppler can be useful for, because we might not be there. The patient suddenly drops their flows and desaturates, and you just want to know, look, do I just need to give a fluid bolus or do I not? And so those kind of things are just very helpful at the bedside for somebody like me wanders along with an echo probe.
30 mils per kilo, it says here.
Oh yes.
Surviving sepsis.
Can we talk about that?
Well, given that you've wrote the thing saying it's bad, okay, you put your name on it. I remember that bit.
Yep.
Why don't we hear from you? Why do you think it's bad?
Okay, so my big arguments against so Adrian is referring to a paper that I was part of with a bunch of wonderful, talented intensivists, the likes of Rory Spiegel, Josh Farkas, Philippe Roller.
Yeah, spread the responsibility there. Why not?
Absolutely. It's not just me. My big challenge with 30 mils per kilo is there's absolutely no evidence to support its use. It was a completely empirical number that was plucked out of nowhere. It involves giving people 2 liters of fluid in a 70 kilo person. Most people are not 70 kilos anymore, so 3 liters of fluid in a 100 kilo person, without really thinking, without really assessing the patient, just giving that to them straight off. The patient may be transiently fluid responsive, but you have to remember that being fluid responsive doesn't necessarily mean give fluids. And also, if you're vasodilated, vasodilation from septic shock and inflammatory cytokines, vasodilation is also a preload responsive state. So all you may actually be doing is delaying giving the person the right treatment, which is actually a vasopressor. So those are my big bugbears with kind of blind 30 mils per kilo to everybody in sepsis. What are your thoughts, Adrian?
Okay, so I think the problem again is not the 30 mils per kilo per se, it's the execution of said 30 mil per kilo recommendation. And what I mean by that is the blindly giving the 30 mil per kilo to absolutely everyone, and then compounding the issue by saying, if you don't give it, I am going to fine you or not appropriately remunerate you for your treatment of this patient. I think that's the bigger problem. I think what's really interesting is what you've talked about there, which ties in very nicely to where do we go from here, which is this whole concept of fluid responsiveness. Okay, so if my thoughts on the fluid responsiveness now is that we should be moving away from it. And what I mean by that is that if you look at the big goal-directed therapy trials of recent years, and this is now moving beyond the Detroit area of USA, okay? Process, Promise, Arise, etc., goal-directed therapy, resuscitation, it didn't show any mortality difference between usual care and early goal-directed therapy trial. And one of the main criticism or discussion points is, have we overly resuscitated people? In other words, you resuscitate them till they are no longer fluid responsive. So you are starting on the flat bit of your Frank-Starling curve rather than being on the steep bit of the Frank-Starling curve. I think one of the change or direction of travel, and therefore where do we go from here, is this whole concept of just because you're fluid responsive doesn't mean you need fluids. And I know Professor Manuel Brain, who is a big name researcher in this field, has constantly banged on about it, and his Fluid Academy, his meetings, etc., they talk about that. But I do think that the rest of the world, dare I say it, is starting to come around to the idea, and perhaps maybe this whole fluid congestion, which I know is an area that you and I are both interested in, is starting to becoming more at the forefront of people's minds. Your thoughts?
So just before I say my thoughts, the Menti poll is now open for kind of where you all think that we should be going from here in terms of research. I will talk about my thoughts on kind of fluid responsiveness. So I completely agree with you. Fluid responsiveness does not mean give fluids. I think that it's kind of ultimately it's a wonderful set of ideas, a wonderful set of principles, but we're starting to appreciate more and more the limitations of completely eliminating fluid responsiveness. And so very similar to what we used to do with PEEP and recruitment, where we would recruit everybody's lungs to the maximal point of recruitment. We no longer do that anymore. We allow a degree of permissive atelectasis in order to prevent lung injury. Perhaps we should be allowing for a degree of permissive fluid responsiveness to prevent congestion. And so I am very much in a place where fluid responsiveness is no longer the target that I used to eliminate. And it's, again, perfusion without congestion is my magic phrase.
And how do you determine that little
that's a
tiny slither of Goldilockness?
The magic Goldilocks bit. I think that's actually really, really tricky. Some of this is, again, it's pretest probability and being a bit Bayesian about it, and looking at the patient, looking at where they've been, looking at the nature of the disease they have, whether they have profound vasodilatory shock from like a toxin producing bug, or whether they just have, or whether what they have is actually a degree of hypovolemic shock because they've just not eaten and drunk for 5 days. I use a lot of clinical examination. I use a lot of echo, both macro circulation echo with kind of echo and stroke volume measurement, but also looking at the microcirculation. So I do look at things like renal perfusion, hepatic perfusion, and of course then I look for markers of congestion. So I look at the lungs, I look at the liver, and I try and come up with a holistic view using lots of the traditional tools plus clinical gestalt plus history. I think you have to spend time with these patients, especially when they're really, really sick, in order to get the best out of them. And that, I guess, one of the things to think about as well is that lots of patients that we call having sepsis aren't really that sick. You give them a couple of liters of fluid, and you give them some Augmentin, and they're better within a few hours. But those aren't really the patients that you and I are interested in. Is that fair?
Look, at the end of the day, I don't wish ill upon anyone, and I want patients to have a really good outcome. I think one of the things that the Surviving Sepsis Campaign guidelines has done well is that it puts simple management strategy. I think simple fluids, antibiotics, tubular cultures, things like that in people's minds. Okay, so the Sepsis 6 that we've got in the UK and internationally in the Western world is pretty much in most doctors' lingo. Okay. What I find very interesting about what you said, and I was just thinking about it whilst you were sharing your thoughts, is you can do this, you can do that, you look at this, you look at that. How much of that is universal to clinicians everywhere? So how much of that is universal to all your colleagues within your department, within your hospital doing it? And how much of that is due to the stars being aligned, you being there, you not being there, so on and so forth? Because one of the things I think guidelines do is that we know whether we like to admit it or not, whether people like to admit it or not, guidelines improve outcomes, even controversial ones such as surviving sepsis. If you look at the before and after of introduction of surviving sepsis guidelines, the vast majority of them have shown improved patient outcomes. Whether it's the individual steps or whether you want to dissect it out, it's a matter of contention and we can discuss it. So my throwback to you is, how much could we protocolize care, or should we personalize? Okay, how do we, as a community of healthcare professionals working with manufacturing partners, how do we genuinely improve outcome for patients with sepsis?
That's a really, really good question. And you talk about, so yes, you've raised a really good point in that standardization of care has been shown to improve outcomes in sepsis and septic shock, based on the Seymour paper. The counter argument, which is a promoter of a more individualized, personalized approach, is the Australian data from ANZICS. So in Australia, and the intensive care community never adopted the surviving sepsis guidelines. They practiced very much individualized care, and they have some of the best outcomes from sepsis and septic shock in the world. But some of this, again, even though their guidelines, they don't follow a standardized guideline, they have a very uniform training program in intensive care medicine that produces very similar like-minded intensivists. So perhaps that's some of it. It's not necessarily about, it's about training people to critically think in the right way and have a uniform, detailed approach to the patient that applies both some standardized measures, some standardized treatments, such as giving antibiotics early or appropriate antibiotics early if you think the patient is septic. Optimizing the macro perfusion, optimizing the micro perfusion, getting source control if you can clearly identify a source, and putting the patients in a high monitored area really early. And you can call that a guideline. Some people would call that common sense, but I think it's about making sure that that's exactly right. It's about
So
making sure
going to
that
get a
that's
call
all
from our
kind of
medical directors tomorrow.
yeah. So
I'm
making sure
looking.
it's all kind of tied together,
I'm
and we're all giving it.
not going to disagree with you. David's joined us as our referee.
I think it's a great question. I personally, I think post-COVID, a lot of us are thinking from an industry side that we need to be really looking at what it means to deliver personalization. What are the needs of you rather than me or her, etc. So, and I think that those are really, really quite key. And I don't know, in the time that we have available, is there anything that you'd like to sort of really tackle, on these questions that we've got? We've got some great questions.
Look at them.
here.
Oh, they're fantastic, aren't they?
A couple of things jump out at me, which is if you look at things such as target parameters, echo, tissue perfusion, catheter-related bloodstream infections. A lot of the themes, at least to me, jumps out at me, is this whole idea that in whatever we do, there is a harm associated to whatever we do. And that is whether we put in this device, whether we do this, whether we do that, whether we target a map of 65 versus a map of 55 versus 80, whether we put in a quad lumen or quin lumen or 7 lumen central line. There is there is a degree of possible harm associated with it. And I think we need to be better as a healthcare community to realize that whilst we have obviously got good intentions of treating patients, wanting them to get better, we just need to acknowledge there are things that we don't know. So for example, I'll use the target parameters, target blood pressure, etc. We think we have an idea in terms of what's good. We think that we have an idea in terms of what's bad. So 30 map is probably bad. 60, 65 is probably okay. Going up higher, 70, 75 is okay, but there is a trade-off to it.
Yeah, but also on that mean arterial pressure area, isn't it obvious that if the patient's mean arterial pressure is 68, that it's going to continue to drop if it's dropping? I mean, isn't it obvious? Isn't that an early sign?
Shagan.
Yeah, I think that's very difficult in that so there is natural circadian variation in things like mean arterial pressure and blood pressure, and there's beat to beat variation as well. I think there's two sides of this. One is the aspect of the deteriorating patient. So if you look back and you look at a patient and you look at them and you look at their well-being, you can often clearly mark out a pattern of deterioration. It's not always very clear, and there was a very recent high-profile case that was published in The Guardian, where of a young girl who died from sepsis, where perhaps it may have been clear, it may not have been that clear. These things are always easier to see in hindsight, right? So there's that aspect of it, and again, this is why this is World Sepsis Day, why we're here talking, to raise awareness and make sure that talk about these signs and how we can recognize these signs. But sometimes it's not so clear, and then you're reliant heavily on collision gestalt and suspicion and looking for kind of things that just don't quite fit, and there you can leap on and make the same diagnosis. Thoughts, Adrian?
I think you're right. I think whenever I think of what could be done better, there is obviously the research clinical side and the answer, but there's also the logistics. How do you deliver safe, consistent care to everyone with sepsis that presents in hospital in a fashion? So for example, let's take Sagan examples of echocardiography, which is mentioned in one of the questions as well. Can everyone that looks after a sick patient, not even just in intensive care, a sick patient in hospital, can that individual echo should that individual be able to echo?
Mm-hmm.
Can we have arterial lines in for all these patients so that we can detect deterioration in the very early stages of illness?
Mm-hmm.
Should all patients who are potentially sick have a central line?
Mm-hmm.
Great
But again,
question
I
from the
think that
chat.
those are really, really great questions, because one of the things, as an outsider looking in, I think you come in and you think all ITU patients must be equal, but they're clearly not. There is still a micro triage process that goes through, and are we being limited by cost, or are we taking clinical decisions? Is it manpower? In an ideal world, would we do more? How do you actually make those decisions? It's tough, I think.
It's very tough. And actually, if we take a further step back and looking at it, I'm very aware that there's a question down. What if you worry about?
Oh, yes.
Lindsay has kindly put in the chat that's if
yeah,
CVC,
Lindsay and
people
also
worry
Nadia.
about
In
septic
fact,
shock.
yeah, we should answer.
Yeah.
We should answer their questions.
Yeah,
we'll come back to it. Nadia asks a question: do we really need a CVC? Great question.
Depends on what you want to use it for, really. So Sagan's already mentioned that in some institutions, and there is evidence out there to suggest that you can give peripheral vasopressors, okay, which is, let me make sure I get the phrasing right for the final trial, non-inferior, okay, with in terms of safety profile. So there is that. So I accept that. The other thing to consider is that if you get it wrong and you have extravasation of your said peripheral noradrenaline, there is associated harm to it. And we being humans and the NHS and healthcare systems being the healthcare system would then go, well, was there a safer alternative? And you're going to go, well, there is a central line. You could flip that and say, well, I don't need to put a central line in because the central line is also associated with harm, pneumothoraces, bleeding, so on and so forth. And like most of these things, it becomes a problem when it becomes a problem. And the retrospectoscope is always of great value, the retrospectoscope.
Yeah,
I have to agree. I have to agree with Adrian. I think a lot of this is going to be driven by the skills you have on ground, your individual policy, costs, and your perceived sense of safety. You just have to draw these risk benefit balances with every single patient. So they're low middle income, they're low resource settings where well, certainly where I come from, where getting a central line into a septic patient is well near impossible. And so their peripheral vasoactives are life-saving. And then, I work in a big, lovely, shiny hospital in the center of London where, we put in a PA catheter at the drop of a hat. It's, it's just what we do. And it's just worth remembering that there's a balance to be had. I can't take the PA catheter to the former setting because it would just be a disaster. No one would know how to look after the patient. You'd get lost, you get infected. It's all horrible. So you just have to make sure you just work out what's best for your patient that you can deliver safely at that point in time.
Yeah, and we've also got another question, I think, from Lindsay during registration, and I thought it was a great question. Is are we overusing the word sepsis, or should we be trying to find a new word?
Go on then, Adrian.
I'll go first. I think, like I said right at the start of this webinar, I think one of the strengths of the Surviving Sepsis campaign is raising awareness, not just amongst healthcare professionals, but also members of the public. I think, like in the same way as we try to refine our definition of ARDS, and we can apply the same analogies to sepsis in the sense that I think sometimes we overcomplicate matters, and then you're going to have a trade-off between making the diagnosis very, very refined, increasing the sensitivity, increasing the specificity, and the trade-off to that is that you're going to miss some people. And you're going to need to make a judgment call with trading off. Now, I just happen to be in the camp, and the full disclosures, I think, for all the criticism of this definition for sepsis, at least people are thinking about it. They might not be correct, ultimately, but I think the fact that they are thinking about it probably saves more lives than not thinking about it.
Yeah. And also, I think reduces issues around morbidity as well. It's not just mortality; it's morbidity, and I think that some of the technologies and also the earlier interventions are preventing escalation into ITU, for example, which I think is a good thing. I mean, good news. One last question. I'm aware of the time is sort of ticking on. I'd like to sort of carry on, but I thought it's a great question just to finish on this. And it's again from one of our people who registered. From your perspective, what are the latest advances in sepsis diagnosis and treatment? And how do you feel that they're improving patient outcomes? So you might just want to take briefly, just have a go for each of you to answer that from your perspective and experience.
Shagan, you go first.
Go on then. I think I'll go first. Okay, so for me, the big thing. Okay, I'll go for the slightly simple. Well, there's two things really I can think of. So one is biomarkers. So there's more and more biomarkers. I mean, procalcitonin is like really, really old now. But we know that procalcitonin is not great in terms of the use as a diagnostic tool. What we should be using procalcitonin for is deciding when to stop antibiotics. So you start the patient on sepsis treatment, you wait till they're getting better, and then day 3, you repeat procalcitonin. And if it's halved, then you stop the antibiotics. That's really how you should use it. But there is a new biomarker I was just reading about actually early on. Well, not that new actually, but pre-sepsin. And this is apparently showing much better sensitivity and specificity than CRP, white count, and procalcitonin. So this may be coming to a bedside near you. The other thing that's coming is all of these kind of bedside PCR tests. So the one I remember is one called BioFire, and that's really quite nice in that it basically you can rapidly phenotype at the bedside. You can basically PCR what the likely infective agents like it to be. So you have people who turn up to an ED with suspected sepsis, and within an hour or two, you can basically PCR out then Streptococcus pneumoniae, and therefore you can then target your antibiotics a little bit better and actually truly personalized care. The second thing, which I thought I'll talk about, is because it's one of the things that is in the research, is genomics. So there's a big ongoing trial, group of trials. I think it's the Gaines group, and it's Gaines and Genocept that have been looking at exactly this, genomics and survival and individual genomic situation signatures that are correlated with survival in sepsis and potentially non-survival in sepsis. So lots of this stuff again will be coming out over the next few years, and we'll be able to find individual human genotypes that are more susceptible and perhaps are more responsive to certain treatments like steroids, for instance. So those are things that I think will be coming soon. Adrian?
So I was going to say that the genomics one is genetics. How much does your genetics play in terms of how well or how badly you respond to therapy, and ultimately how badly or how well what outcome you will have? Because one of the things I feel very strongly about when people say personalized versus protocolized care, as you know, Sagan, is that I often cynically say that when you personalize care, who are you personalizing it to? Are you personalizing it to the clinical team that's treating you? Or are you personalizing it to the patient? Now, intuitively, you say, well, let's personalize it to the patient. Really? Think about it. So the arbitrator to that, or the solution to that problem, is all these rapid genetic assessments, so you can phenotype the individual, truly personalize that patient in front of you. So I am excited, and it's probably the thing I keep my eye out on the most outside of ultrasound related stuff.
Okay, that's brilliant. Thank you so much indeed for joining us. It's now gone 22/7 Central European time, and we really need to wrap up what has been, I think, a fascinating insight into thoughts and the challenges really of sepsis and patient management. Guys, it's a big thank you from the Vigon team for just hosting this and sharing your thoughts and ideas, and thank you for all the preparation that goes behind it. And thank you as well for joining us and raising your questions. I'm sorry, we just had so many questions. We literally had about 100 questions that we just couldn't get through in the time that was available. If you'd like to find out more about any of the subjects, you want to contact us, you want to get connect with Segun or Adrian, please just connect with us in the usual ways. But in the meantime, thank you very much indeed, Segun, and thank you very much indeed, Adrian. I hope you have a really pleasant evening. Thank you so much. Cheers. Bye, everybody.
Thanks for having us. Take it easy.